of course, here comes the medical gaslighting. So what
Yeah.
ensues? You pop around to all the specialists trying to get someone to listen, even though I said, it's my gallbladder, cannot process fatty foods. It's just not happening. I'm on digestive enzymes. I'm on activated charcoal. I'm doing all of the things that you would do holistically, lifestyle and functional medicine. Nothing worked. So finally, I got a surgeon to listen. She did a nuclear scan for the gallbladder, and I was functioning at less than 10%.
Wow.
I couldn't keep it. It was doing me no good, and I was losing weight. I couldn't afford to lose any more weight.
Hi, everyone. Welcome back to the Integrative Women's Health Podcast. I'm here with Dr. Ginger Garner. I'm so excited to share with you our conversation today about endometriosis, her experience, and her vast experiences as a clinician working with people with this condition and what she's learned in the last couple of years. So welcome, Ginger.
Thank you. Thanks for having me, Jess.
So let's start with your recent personal experience with endometriosis. And I would love to learn more about your personal and clinical insights on how orthopedic conditions can sometimes mask endometriosis.
Yeah, that's a really good question. And it's a place that I've personally lived for, oh my gosh, over a decade, but really my whole life, if you take it, retrospectively. And the current theories of the genetic catalysts for endometriosis, then it's been with me forever, right?
Yeah.
But in the last 10 years, I think the first time that I really began to appreciate the connection, or the gap, I'll just say the gap between sports medicine and pelvic health, was after I gave birth to my third son. And I had a birth injury where a very well-meaning L&D nurse, but nonetheless one that maybe wasn't a bit up to date. And of course, back then, they weren't paying attention to what they were doing with women's legs during delivery. And so my hip just got utterly destroyed. However, it brings up a really important first point. If endometriosis was obviously already there all along, how many people can be misdiagnosed with a hip labral tear, femoral acetabular impingement? Not that they don't have it, but when we read the literature, we clearly know that a labral tear doesn't have to cause pain. And FAI is not necessarily a surgical indication to have this massive hip preservation surgery, which I went on to have 3 years later after he was born. So when I look back, there's that huge overlap between orthopedic conditions, which can be very valid, just like the 4 surgeries I had prior to endometriosis. The final excision surgery, hopefully, will be the final excision surgery, where each time it wasn't that, yes, you could say, should each surgeon have biopsied the tissue to make sure that it wasn't endometriosis? Yes, 250%, absolutely. And they didn't. So that's the first problem. But the second point is that each time they went in, they found another very valid driver of the issue. And so now, as a clinician, personally, this has been an incredible experience I wouldn't wish on anyone. But the flip side of that is it's made me so much more aware of and very picky about how I go about evaluating that overlap between orthopedic and pelvic health, knowing that there could be these underlying systemic drivers like endo.
Well, and especially, so if we're putting our clinician hat for all the professionals out there listening, or for people struggling with essentially a multiple continued kind of surprising, if you will, orthopedic injury. Now, certainly a birth injury can be very significant, just like a sports injury. But the fact that you had multiple hip surgeries without the underlying problem being corrected, despite doing pre-op care, doing good post-op physical therapy, working on alignment, I think a big red flag for me that this has some systemic or cellular component or system, I guess physiologic systems component, is that you had to have multiple surgeries on the same joint.
Well, the surgeries actually ended up being all sorts of a la carte various things.
Okay.
Yeah.
Mm-hmm.
Which makes it even more colorful.
Yes.
And it really underscores, I think, what we're trying to bring to light to people suffering with endo or these overlapping issues too, because it's not just lesions, for example. So in
Mm-hmm.
this case, what happened, which now in retrospect, things come together and look a little bit more clear, but when you're living them, you're always on the edge of total disability, not being able to manage, your work. And
Mm-hmm.
I have a private practice, I have a continuing education, company, just like you do. And so it can deeply resonate with anyone who's self-employed, with anyone who has to maintain their job and just can't step away for these incredibly painful chronic experiences. They have to keep going. And
Mm-hmm.
so what happened was initially there were red flags all along the way that when you grow up in a rural area without healthcare, and the very first instance, my first surgery was two for probably a very valid issue, which was a ruptured appendix.
Mm-hmm. Mm-hmm.
So then as time goes by, you think when you have a second surgery and they find adhesions everywhere,
Mm.
you think, well, that original that surgery in a tiny hospital where they just vertically opened me up at 2 years old, that was messy,
Yeah.
right? So you think
Yeah.
about that. Everyone has adhesions post-op, abdominal surgery or orthopedic surgery. You can have, adhesions, and that's why therapy is so important for follow-up and follow-through. So you can get down these little rabbit paths. And so one of the surgeries, for example, was I began to have right upper quadrant issues. So for everyone non-medical listening in, um, gallbladder area pain.
Mm-hmm.
And I knew that it was as a healthcare provider. I'm like, oh, my gallbladder is quitting on me. Why?
Mm.
Other than being female, I have no risk factors for this at
Mm-hmm.
all. Of course, here comes the medical gaslighting. So what
Yeah.
ensues? You pop around to all the specialists trying to get someone to listen. Being a healthcare provider sometimes makes absolutely no difference. And in
Mm-hmm.
this case, it didn't. Even though I said, it's my gallbladder, cannot process fatty foods. It's just not happening. I'm on digestive enzymes. I'm on activated charcoal. I'm doing all of the things that you would do holistically, lifestyle and functional medicine.
Mm-hmm.
Nothing worked. So finally, I got a surgeon to listen. She did a nuclear scan for the gallbladder, and I was functioning at less than 10%.
Wow.
So it was
Yeah.
already dead for
Yeah.
all intents and purposes. I couldn't keep it. It was doing me no good, and I was losing weight. And
Mm.
I couldn't afford to lose any more weight
Mm-hmm.
after going through a year. So when she went in, she found adhesions everywhere.
Mm-hmm.
They were
Mm-hmm.
in the transversus abdominis, all the layers of the abdominals. The liver was scarred down to the respiratory diaphragm, making breathing really painful on a regular basis. That had happened my entire life, right?
Yeah.
Just no one really paying attention. Did they biopsy for endo? No, right?
Mm.
So that's
Yeah.
another surgery. And then there were others after that came.
Right. So really, your story is such a stunning example of exactly what happens in our conventional system. It's like this issue, okay, take out the appendix. This issue, okay, take out the gallbladder. No one's really kind of like, well, why are there all these other adhesions? That's not really normal for
Mm-hmm.
just a gallbladder challenge.
Mm-hmm.
Certainly, it's a little tricky given that you have this history of the 2-year-old kind of
Messy.
messy
Yeah.
appendix surgery. I'm starting to wonder, have you done any genetic testing? Because more and more I've been looking at the genes of people with endometriosis and finding PAI or one or SERPINE1 SNPs. So there's this tendency towards fibrosis, if you
Mm-hmm.
will. Have you
Mm-hmm.
seen anything like that in your experience?
Yeah, I have done genetic testing. I'd have to go back and look for those particular SNPs.
Mm-hmm.
It's been an all-encompassing, journey of helping other women through it, and while I was just kind of silently dealing with it on the other end.
Yeah.
The other thing to throw into the mix with the genetic drivers, of course, I have multiple family members, with endo. My mother had incredible endo that at the time, you know what I'm going to say that they did, they treated, they gave her a everyone together, hysterectomy.
Hysterectomy. Yes. Oh, geez.
Which did not, no, that didn't help. That wasn't the cure. But another interesting surgery that I had, speaking of both genetic tendency towards, fibrotic issues,
Mm-hmm.
was a surgery where I ended up in the hospital on day 2 or day 3 on my, PCA morphine pump because they had no idea what was wrong. With peritonitis, of course, now inflammation is everywhere. Things are spreading and growing. They went in and said, oh, it was just another appendix.
Hmm.
Yeah.
Fascinating. Oh my gosh.
Stuck in another rural hospital, unable to transfer anywhere after being so incredibly sick for several days and just getting worse and worse and allowing them to go in and do a scope.
And so how many years ago was that, roughly?
Oh, gosh. Over a decade.
Okay.
Mm-hmm.
Yeah. I think there's a few key points I want to emphasize here. One, as you mentioned a couple times that, your living situation happened to be in more rural areas. Mm-hmm. And I think this is something we're not talked about. We don't talk about it enough or isn't acknowledged enough. The access to even surgical skill or experience that you would get in a large city or teaching hospital environment is very different from what you could get potentially at a community hospital in a more rural area. How do you think that impacts essentially access to care?
I think it takes out entire states, not just regions, because one surgery I had at a teaching hospital at UNC Chapel Hill, where I went to PT school, but which is an excellent school, excellent teaching hospital. I now live in sandwiched between, we're 1, 2, and 3 largest cities in North Carolina, all within an hour of each other. So I live right in the middle of the mecca of healthcare and what we have. So I think that it's a passion point for me to. It's driven my actions since then to, like I mentioned, run for state senate, and then I'm currently our legislative chair for American PT Association in North Carolina, and several other roles that are all legislative advocacy, policy writing positions, because it's that important, having lived it and also seen family members suffer unnecessarily and one pass away unnecessarily.
That's horrible. Are there any recommendations you have for health professionals or individuals listening to this who do live in states or regions of states that don't have very good access to, we talk about the limitations of good conventional medicine in terms of like everything being siloed, but there's also just the limitation to just flat out all kinds of care, as you said, when you're in an environment that just doesn't have the skill set. And knowing kind of the corporate drivers behind healthcare, is there anything that sort of individual practitioners could start to do to shift this access challenge?
Oh, goodness. I'm thinking about it on all levels, actually. I'm thinking about it from the practitioner level. And I have been in, I think, different camps. And what I mean by camps is different camps in terms of being frustrated with the limitations of our current professional organizations, where we feel like there's underrepresentation or they're not addressing the 40,000 foot view of access fast enough or in all of the right ways, or speaking from PTs giving us direct access in all states. So one of the things that we can do, because I think when the public can very easily be misinformed that, for example, if they have back pain, they go to an orthopedic surgeon as an entry point of care, right? When the research clearly shows us, particularly from the US Army, that when PTs are a primary care provider for orthopedic issues, back pain is probably the most common one because it has such a systemic impact on us. And nearly everyone's going to have it at some point, right? That it costs less. PTs order less imaging. They have more rights. They can order imaging in the US Army. They order less imaging. The outcomes are better. The patient is happier. It costs the system less. And for some reason, we're not applying that evidence, across PT access in the US. So from a practitioner standpoint, for all the PTs listening or anyone who cares about having PT access, is get involved. Know who your representatives are, particularly at the state level. And I say
Mm-hmm.
state level because many people think, oh, I'll contact my Congress member. Most of the decisions that give you critical access to care are made at a state level.
Mm-hmm.
And so if you are a healthcare provider or a person, a consumer of healthcare, know who your representatives are and know what their stances are in terms of public health policy. You might be very shocked to learn who you're actually voting for is a reason that rural health hospital in a far-fetched area in your state closed down because then they didn't have the funding for that or they couldn't keep the doors open. So know who you're voting for first. If you're a practitioner, as much as if you love APTA, wonderful. If you hate APTA, okay, fine. But it's the organization that we have that represents us right now that is working hard to be able to improve access. And if we don't support it, you have no chance for improving access to healthcare, particularly if we talk about the efficacy of PTs and how great they are at well checks. Imagine if we could have a well check every year, right? From a pelvic PT. Of course, we're talking about pelvic PT, but also ortho. It would be amazing and would cut down on unnecessary series of injections for back pain and things that we absolutely know don't work, especially when people come in with the hip issue or the endo issue. It allows us to then, tick those red flags and go, you know what? I think you need a referral to this provider. So yes, I got a little bit into the political realm because healthcare is more important than politics. So I don't care what party you're a member of, right? I'm talking to the listener here. Healthcare is too important to be a party or a partisan issue. So if you get involved, great. If you are in a state and you're wondering if you have good access to hip preservation specialists, endo specialists, which I just want to say for a moment, you need to go to an endo excision specialist or an orthopedic surgeon who only does hip preservation, nothing else. Otherwise, you're not going to have good outcomes.
Yeah. Yeah. So to sort of summarize that, I think one of the key things is that physical therapists, in a way, are uniquely positioned even within the conventional medical system to provide more holistic care because our training is actually cross-disciplinary from the standpoint of neurologic, orthopedic, pelvic health, reproductive, pediatrics,
Longevity,
geriatrics. Yeah. And so women's health, men's health. And so I think that we are uniquely positioned within the conventional medical system, which does give then greater access to a wider population just because we, in many cases, can access insurance or insurance payment systems, which are very far from perfect and,
Oh
not my favorite system. We could go deep into that, but it does give access to people with less financial resources to be able to then, and physical therapists within our training, if we are subspecialty trained or not even subspecialty trained, like have additional postgraduate training in nutrition, can also provide that functional medicine perspective. Now, functional medicine is not a specialty. It's a perspective that allows for that root cause thinking. So if a physical therapist sees a person like you who had multiple hip surgeries, organ surgeries, history of adhesion, family history of endometriosis, there's a lot more red flag opportunity because most orthopedics don't learn about endo. Most general surgeons don't learn about endo. Excision surgeons, which are very skilled surgeons, are essential for endometriosis care, but are relatively rare within the world, not only this country.
Hard to access.
So I think if you're a person listening to this, or even a practitioner listening to this, who feels like there are multiple things going on that started either at birth or in early pre-puberty, puberty, that there's this intuitive sense that they're connected, but everyone's like, oh, that's just how surprising. Like, you now have a gallbladder thing. Oh, how surprising. You now have another
second appendix.
Like another one just grew or
just
whatever.
There.
And so, especially because endo has a lot of digestive symptoms. So you were able to look back and connect some of those. Let's talk about like your symptoms as a person just living in this experience that didn't seem connected before, but now that you have the endometriosis diagnosis, what seems more obvious in retrospect?
Yeah, I feel like I'm a little bit of a weird unicorn in that, and I've met a few other patients that have come in with endo and wide-ranging broad symptoms, but yet have been able to get pregnant. But that didn't mean that I struggled hardcore with infertility for a decade, over a decade.
And so you were able to get pregnant, which is one of the reasons why people weren't looking for endo. And yet it was a struggle.
Yeah, I was already a practitioner using that functional medicine perspective, Ayurveda, yoga, all of the things that we know about integrative and lifestyle medicine that work to mitigate what's going on systemically with, estrogen, dysestrogenism, dyscircadianism, all of the things that we know, environmental pollutants that have estrogenic effects that would drive growth. I was really hardcore controlling for all of those in order to try and treat the fertility issue, which ultimately worked. It
That's
worked
great.
enough.
Yeah.
But at the same time, it delayed diagnosis, right?
Sure.
So, and that's why I say weird unicorn, because I believe that had they gone in, I would have, adenomyosis was a secondary diagnosis that was inconclusive from the lab. The surgeon said it looked just like it, which meant I would have had a hysterectomy before I had a chance to be pregnant.
Yeah.
Which then, it gets me emotional to think about. That's why I'm so passionate about helping women with this issue, because some of them are coming in, and there are so many functional medicine perspectives that can be taken to get them to that success point that, I was in. Was I pain-free during that time? No way. The drivers got so bad, particularly as you enter into perimenopause, into menopause, where, and this is the other myth that we can go ahead and dispel, is that endo gets better as you enter into perimenopause and menopause, which I had 2 endo patients, I think, last week, and both of them had heard the same thing. They had hysterectomy and they had their GYN say, oh, don't worry, it'll get better at menopause. And I just had to lower my head and then just say, I'm sorry, that's not correct. Maybe if I wasn't almost a 30-year veteran in PT, I would have been more diplomatic about saying it, but I just don't have time to waste on endo illiterate professionals anymore, right? And so I'm just, setting that record straight. So those symptoms that I had, obviously infertility, which so many women with endo have, and respiratory pain, which to the average ortho, right, to the average OBGYN, they're going to entirely ignore that, right? They're going to say side stitch, go hydrate, or you just have anxiety, take a deep breath. Absolutely not. When I've had my respiratory diaphragm cleared from my liver twice already. Respiratory pain, really horrible cycles that they're heavy because you're a pelvic PT, right? They're heavy, they're too heavy, but you also start to think about again, from a functional medicine perspective, how well is my liver metabolizing the estrogen that it has? Am I in this kind of dysestrogenism situation or season? So I treated it, and guess what? It got better, right?
Yeah.
So when you're self-treating these things, you can mitigate them, but really, really heavy dysfunctional periods to the point of having persistent, pervasive anemia, even after the cycles were done, permanently done, still anemic. Malabsorption, things that we don't consider. Strain on my labs, right? I don't think that if you're not a healthcare provider, maybe you're not paying attention to it. But I noticed that in spite of eating a really healthy, anti-inflammatory, Mediterranean-driven type diet, I wasn't absorbing antioxidants. I wasn't
Mm.
absorbing
Or there
calcium.
just wasn't enough at all.
Right.
Like you
Like,
just needed so much.
right.
Yeah.
Even with supplementation. So with the diet plus supplementation plus, you know, bone density, weight bearing, building, exercise, and all the things that we know are good to prevent these issues from happening, they still were happening.
Mm-hmm.
And so that the kind of the breaking point for symptomology for me was I've had this happen frequently, but of course it can be very much passed off and ignored. Fortunately, I never had any bladder symptoms, but there were lots of bowel symptoms.
Mm.
There were stretches of kind of unexplained SIBO that made absolutely no sense based on what I do for a living and how I practice. So persistent things like that. But really, the last one was nerve related. So
Mm.
think sacral plexus, sharp searing, people might mistake it for sciatica, right?
Mm-hmm.
Type pain.
So for people who are less clinical, that's like all the nerves that come out of
Mm-hmm.
the lower part of the spine. So it could be anywhere in the back and the hips and
Mm-hmm.
the pelvis and down the legs,
Yeah,
burning,
like
all of that.
piriformis syndrome, a thing
Yeah.
that just rarely is a driver of anything,
Yeah. Just
That's like
butt
IT band
pain.
syndrome,
Yeah.
piriformis syndrome. I'm like, don't talk to me about it. That's not an actual diagnosis.
Right.
But that's what it would have been mistaken for, is piriformis syndrome. I would have been sent home from the ER with, more drugs, more meds just to mask everything.
All the pain.
But
Yeah.
I ended up in the ED anyway because
Mm-hmm.
I couldn't breathe. I
Mm-hmm.
could not stand up. I couldn't walk. And I went through these bouts that I've actually told no one before now. So this is the first time I've ever shared this story.
Thank you for being so vulnerable.
Yeah, publicly, where no one knew this because you didn't want to draw attention to yourself. You're a clinician. You need to go to work and not be the sick one.
Yeah.
So I
Yeah.
would have to take days off because I couldn't walk. I'd have to ambulate around my house with a cane. I could
Mm.
not bear weight
And
on my
the
leg.
shortness of breath was because it was so painful, or did you actually have like lung
I didn't end up having
pathology?
thoracic endometriosis. The adhesions, which of course can come from lesions, were pretty terrific. And of course, they had been released once already, but without a biopsy and knowing what in the world was going on there.
Right.
So between the nerve pain in the lower body and then the respiratory pain in the upper body, my middle son and my husband had to carry me to the car. And I was like, I just need to know it's not catastrophic. It's probably endo. So I got to the ED and I was like, listen, I have triaged myself. I do not want your pain meds. I just want to make sure there's nothing else catastrophic going on and then send me home. Like,
Yeah.
seriously. And that was kind of the breaking point. I was like, okay, it's clearly not getting better. I know what this has to be. I have mitigated it, mediated it, managed it all of these years. I managed to get 3 kids, before they had to basically take everything out. I feel lucky that I got that far, and that was it.
Yeah. Well, first of all, thank you for sharing that, because I think it's so valuable for people to recognize. I gave a talk back in October at the Pelvic Conference in Atlanta. And, the reality is that practitioners and patients are not like 2 different groups of people. There are people who are practitioners and there are patients, which is absolutely everybody.
Yeah.
And when practitioners become patients and that they have physical challenges, they might understand them better or more quickly or from a particular perspective. But we're all still human, and having those experiences is not something we're insulated from because we have particular degrees,
We're still in the same waiting line as everyone else for the person who might be able to listen or give you an answer or gaslight you. We're in the same queue as everyone else.
And so a couple things. I think in the world of COVID and post-COVID, your symptoms of acute nerve pain and acute respiratory pain driving you to the emergency room is actually a good thing to do because of the clotting challenges that we're now seeing in women, especially perimenopausal and menopausal, who who have had COVID or COVID vaccine, either one at any
Mm-hmm.
time, which is pretty much absolutely everybody at this point, usually both.
Yeah.
So I think that's a red flag for people to just be aware of, that that's something that does have to be more urgently ruled out if you have these
Mm-hmm.
symptoms. And it could come from something else, but in the world of a, chronic vascular condition that everybody's had. And then the second thing I want to talk about a little bit more now is, so I recently did a podcast full episode on endometriosis in perimenopause and menopause, and the data shows us that actually endometriosis is diagnosed in about 14% of perimenopausal women, 14-15%, and about 5%, 4 to 5% of postmenopausal women. I think two things are happening right now, and I would love your opinion on this. One is that we have cases like yours, which is a clear long-term delay of diagnosis. Your diagnosis was managed because of your knowledge, and also because you had other drivers that seemed
Mm-hmm.
to be the pain driver or the symptom driver, and you just didn't have diagnosis until you were, I don't know if you're perimenopausal or menopausal, but in that group, like over
Mm-hmm.
45.
Yeah.
Or I actually think, though, there is a world in which some of these diagnoses are that the trigger itself for endometriosis expression, particularly in perimenopause, when we have the changes hormonally, is actually, endometriosis has a genetic driver, but it's not always fully expressed.
Mm-hmm.
There's a trigger of endometriosis. As an example, I'm always talking about, I have a client who has an identical twin sister who does not have
Yeah.
endometriosis. So I think sometimes perimenopause is the trigger, and people are having essentially new onset endometriosis at perimenopause. What are your thoughts?
I think that could be absolutely true, because if you think about the world we lived in, gosh, even in the 70s, but
Mhm.
go back further than that, right? And of course, I was born in the 70s. So I turned 50 last year, so it seems like the 70s were 30 years ago, not 50 years ago.
Agree. Yeah.
So now I have to go back 70 years to the world we used to live in, where there weren't thousands and thousands of chemicals that were estrogenic and endocrine disrupting. And so for everyone listening, that's like screwing up your hormones and your
Yeah.
balance, and thrusting, whether it's children entering into puberty earlier, or we have this complicating factor of, even without the pollution, when you go through perimenopause and menopause, you have these hormonal dysregulations, but then add in the environmental aspect of it. And why wouldn't that be true? Why wouldn't perimenopause to menopause be a valid onset or a driver of endometriosis for some women? I totally agree.
Yeah. Yeah. So this has been so informative, because I think your story has so many nuggets of insight for people that may be wondering, like, what the heck is going on for me? Like,
Yeah.
do I really have a second appendix? Like, what is going on? And your story really highlights the diversity of symptoms that can be expressed with endometriosis. Is there anything else you want to share about, okay, let's say you now get your diagnosis, whether you're in perimenopause, menopause, or earlier, and you've had good, skilled excision surgery, you found that surgeon, and we talked a lot about this in our prior episode with Shannon Cohn and
Oh,
Sally Serrell. So
awesome.
people can go back and look at those for like great resources for surgeons. And then now that you're living in the after of good surgery and clear diagnosis, what's kind of your day-to-day routine? Because it's not like it's just over. You still have to take care of your
Yeah.
systems.
Yeah. It is two-part, really.
Mhm.
Two-part meaning what I'm doing as a person. Now, it's inevitable that I'm going to pull my training in integrative medicine, lifestyle medicine, and all of the things that we can do with the functional medicine approach. I am pulling that into my pelvic PT. So
Yeah.
there's two arms of it. There's the integrative part, and the more holistic, 40,000 foot view that you get by saying, okay, I need to manage stress, obviously. But I also need to make sure that my liver can metabolize the estrogen that I have, since one of the at least four ways that endometriosis is a systemic condition is driven by, gut health, inflammation, estrogen. And so I need to control for that. So I'm looking at, obviously my day-to-day nutrition and making sure that between nutrition and environmental factors that I am controlling any kind of dysestrogenic things that I could come in contact with, which is everything from the soap and the shampoo that I use, that to making sure that foods are whole and plant-based.
Mm-hmm.
There's the stress aspect of it and managing that, and also making sure I get good sleep. That's incredibly important, which as progesterone tends to tank, then that means looking into whatever HRT or MHT in this case is going to be most appropriate, especially given, the endometriosis background, which I've thankfully found an amazing balance on that, where I get great sleep, I have good energy levels, I don't have any, issues like metabolic issues, weight management struggles, because I'm controlling for those, those variables through lifestyle medicine.
Mm-hmm.
But when I get past that plus physical activity, obviously,
Mm-hmm.
which is kind of the bread and butter of, of physical therapy, and making sure that I get enough foot to ground activity in terms of weight bearing, prevention of
Mm-hmm.
osteopenia, and osteoporosis,
Especially
incredibly
all
important.
those years of like lack of
Yes.
nutrient absorption because
Yes,
of the endo. Yeah.
exactly. Because my bowel was in the wrong place. I'll just put it
Mm.
that way. It was in the wrong place. That's where the thrust of all the lesions and everything was. It was, there were deep infiltrating lesions there. Explained absolutely every, symptom and sign that I would have ever had. That's important to me, to then treat that from a pelvic PT visceral mobilization perspective. So then when you look at what I need to do on an ongoing basis, pelvic PT will never end after having excision surgery.
Mm-hmm.
I also had a hysterectomy at the same time. They were able to preserve the ovaries. They actually survived
Oh, great.
um, all those decades, which is amazing, and preserving the cervix as well. So some good things that came out of it, but also there's the bit of a red flag for women who have or tend to have hypermobility. So hypermobility
Mm-hmm.
and the overlap with endometriosis is important. So from a pelvic PT perspective, in treating myself and treating anyone else, I'm going to look for aspects of hypermobility, because then that puts women at increased risk, myself included, of pelvic organ prolapse,
Yeah.
of urinary incontinence, of bowel issues. And so I am doing all the treatment stuff that I would do for anyone else. Plus, I have to be very honest too, and with myself, and say, I can't do all that myself. So I have to get other clinicians to go in and do internal work. I can't do my own internal work. I can image myself, and so I'll do ultrasound imaging and see, where's the anorectal canal? Where's the bladder? Is the bladder neck sitting up high enough, or what do I need to do about that? So hypopressives is one thing I found really, really helpful.
Mm,
Visceral
nice.
manipulation and mobilization, super helpful, especially myself included. Again, women who have the tendency not to scar well and not to maybe heal as well. We want to make sure that we're doing everything we can to mitigate adhesions in that way. So I use dry needling. Again, I use VM, visceral mobs, and that's been really, really helpful. But that's kind of a day in the life, if you will. Fortunately, I've not had a day's return of any of that pain, at all. None of the severe pain. Now, I'm just dealing with the post-operative. It's been a little bit over 6 months, which is
Mm-hmm.
still early,
Mm-hmm. Yeah, yeah,
really
for
still
sure.
pretty early.
Yeah.
Carefully watching, gut microbiome health, and slowly getting back into physical activity. For example, 2 weekends ago, I got back in the saddle,
Oh,
literally.
yes.
For the first time, I cantered, which is a lot of downward pressure gradient on your pelvic floor. And it felt great. It felt wonderful. So, yeah.
That's really nice.
Yeah.
Now that and we will just end on this, like now that you've gone through this experience, have your vast knowledge that you have from your 30 years of experience, and then your own kind of lifetime of navigating this disease, is there anything you feel inspired to change about kind of your own life vision, stress, career, work, like downshift, upshift, change at all? How has it
Yeah.
impacted that?
How has it impacted that? in the midst of scheduling excision surgery last year. I was already planning to take a sabbatical. I've never taken one. I'm self-employed, so it's not like I work for an academic institution and I can just get leave, right?
Yeah.
You stop working, you stop getting paid, right? It didn't matter, right? It didn't matter whether or not I had that steady income if I didn't have my health. And
Yeah.
so I planned a month off, which
Mm.
I've never taken before, unless I had surgery. And I've had major surgery so many times that that absolutely doesn't count. Being
No,
postpartum with 2 kids under 2 does not count, right?
not a sabbatical.
No, that is not a sabbatical, since we're defining what breaks are, right? So for all the women out there listening, just because you took time off postpartum, that is not a break. Surgery
Yeah.
is not a break. And that's the only time I had ever taken a break, is forced breaks for these
Mm.
catastrophic things that were happening. So I took a month off
Yeah.
and I came back and changed everything,
Yeah.
everything about what I was doing. I'm winding down a big segment of my continuing education business, not to end it, but to rehome all my continuing education programs
Mm-hmm.
so that I'm no longer managing those. That's a huge, undertaking, as you know, because
Yeah.
you run an institute as well. So winding certain things down, shifting my focus, in clinical practice, changing my schedule, making sure that I actually carve time out to go to the barn and and ride, things like that. I mean, we got one messy, beautiful, amazing, terrifying short life,
Yeah.
and there's no reason to waste a second of it. Women are so strong in what they have to come up against with workplace discrimination, sexism, medical gaslighting, specifically in pelvic health, and not being taken seriously. That claiming your like total, I guess I use a voice to pelvic floor approach in treatment. So I use
Mm.
it kind of trauma informed too,
Mm-hmm. Mm-hmm. Mm-hmm.
to claim the power of your voice all the way down to your pelvic floor
Yeah.
is important. That you're heard, that you use your voice in a way that you want, that your spine feels a little stronger, right? That you stand up a
Yeah.
little taller. That's my mission. And anything that doesn't align with that, I can just happily say no to. And so, yeah, it's changed everything.
Thank you so much, Ginger. Thank you for being here. Thank you for sharing your insights, your story, your skill, your perspective. Where can anyone who would like to find more about your work or come and work with you as a client, where can they find you?
Or a clinician, come
Yeah.
work at the practice.
Yeah. Come work with you. That'd be great.
Yeah, we're looking for people. Well, a couple of different ways. One, if you're on Instagram, just you can find me at Dr. Ginger Garner on Instagram, also on YouTube. I have loads of free content and plans in the works for other things that are offered. So you can come give me a follow on YouTube. I'm always talking about the voice to pelvic floor perspective and my ongoing journey with endometriosis. And you can also find me at garnerpelvichealth.com in the clinic. I do free consults. It does not mean that you're going to end up seeing me. It might mean that I point you to, an excision surgeon or a great pelvic PT. Let's say I talked to 2 people from Michigan last week. So
Mm, mm.
I just want to get people pointed in the right direction. If I can help you in any way, I will. So you can go to garnerpelvichealth.com for first consults free, and integrativelifestylemed.com if you're looking for training in, obviously, integrative and lifestyle
Yeah.
medicine. So that's how you can find me.
Thank you so much again for being here. Thank you for so vulnerably sharing your story, and good luck with everything, including
Thank
hopefully
you.
more course and sabbatical time in the near future.
Absolutely. I'm getting ready to go to Scotland soon. So, yeah,
Oh,
I'm going to
great.
take off and go there. Thank you so much for having me on your podcast. It's amazing. You just mentioned Sally and Shannon with the endo episode. That's fantastic. Y'all have to go listen to that if you haven't, because that's going to be a great one. I know.
Yeah.
I've had the good privilege of having them on my podcast as well, which I forgot to mention.
Oh, yeah. Also, follow your podcast. What's the name of it?
Yeah, the Living Well podcast. It's about ending medical gaslighting in women's and pelvic health.
Excellent. All right. Thanks, everyone, for joining us today, and we'll see you next week.